Abby. I am pleased to introduce Dr. Dan Solomon to give this talk today. As you can see on the slide, he is Professor of Medicine and the Matthew Liang Distinguished Chair and Chief of Section of Clinical Science in the Division of Rheumatology, Inflammation, and Immunity at Brigham Women's, and has an appointment at Division of Pharmacoepidemiology as well. Dr. Solomon has been for years involved in various types of clinical rheumatology research, which include both epidemiology and clinical trials. And he's going to talk to us today about a method I'm excited about hearing about, which is target trial emulation as an example of causal inference modeling with application to osteoporosis. Dan, whenever you're ready.
Super. Thanks so much, Kelly, for the invitation, and glad to speak today. Really what we do most of the time in clinical research in medicine and rheumatology specifically, is that we try to determine cause. We're often using observational data, which is difficult to infer causation. But over the last decades, more and more research has been done in epidemiology to develop an improved set of methods for causal inference. And target trial emulation is one example that we'll discuss today. So again, we'll think about the principles of causation in clinical research, and we'll think about ways to improve causal inference through study designs like target trial emulation and how that might limit bias. And the reason we do this is because medical research is often confusing for experts as well as the casual reader. You spin the dials and you see that one exposure can cause an outcome and in a certain group of people. And it seems like, from day to day, week to week, month to month, these associations are always being discussed in the lay press. And I think as medical experts, we're asked to try to explain them. And so, I think understanding the methodology behind these studies is really critical for all of us who practice medicine or practice research in clinical medicine. And I want to start just with, kind of the example that most of us who have taken a class in epidemiology know, which is the Broad Street pump. This is kind of, John Snow often is considered the grandfather of epidemiology for his work, boots on the ground work in trying to understand the cholera outbreak of 1854 on Broad Street. This is in London. And what I'm showing you in the figure is in black are the cases that he was able to collect of cholera mortality. And in red dots, these are the pumps. And there was a whole debate going on whether there was some, whether cholera was waterborne, like we know it is, or whether it was from bad humors, miasma. And again, the dots help to show the association and through really a proximity to the Broad Street pump, the BSP. And, what ended up being clear was that there was a mixing of infected fecal matter with drinking water causing the cholera. But the exceptions to the rule were really important. So the Broad Street pump is right here in the center of the figure. And you can see that there were no cases right here, even though the people who were living here would live closest to the Broad Street pump where there was infected water, cholera-infected water. But these people actually lived in above an alehouse, and so they didn't drink water; they drank beer. And you can see that through this mapping of cases and mapping of the presumed exposure, these pumps, John Snow was able to develop the inference that the pumps, specifically the Broad Street pump, was causing the cholera outbreak. And again, this was borne out through understanding that there was a mixing of fecal matter with the water being pumped through the Broad Street pump. And again, that you can, if you're walking around London, you can see the Broad Street pump. It still exists, obviously the handles. And John Snow famously took the handle off the Broad Street pump, and the cholera outbreak slowed down. You've also probably, know who this man is, Austin Bradford Hill. He talked about Hill's criteria of causation. He was another Englishman who wasn't able to go fight in World War II. He had TB and was in a TB sanatorium, and was able to, he survived TB and was able to study medicine and epidemiology while he was recuperating from TB. And set out these criteria for causation that are listed here. I have 1 through 3 kind of larger because I think these are more important and probably have stood the test of time compared to 4 through 9. Temporal relationship is critical. The strength of the effect size can be critical. The dose response relationship can be critical, but of course there's times when you reach an asymptote and there's really no dose gradient above a certain level of exposure. And then some of these other criteria for causation, I think, are, sometimes are borne out, but not always. And why do we want to know what works in medicine? And as someone who's trained as a pharmacoepidemiologist as well as a rheumatologist, this is what we think about in drug epidemiology: is can we figure out the effectiveness of a drug when we're trying to make a decision? And we're making those decisions every day if we see patients. And again, this is stuff that I borrowed from Miguel Hernan, a colleague at the School of Public Health here. Obviously for clinical practice, we need to understand whether we're treating with A, methotrexate, or B, Enbrel, or A, Fosamax, B, denosumab for osteoporosis. Do we need to treat the patient now, or can we wait? That's obviously an issue for osteoporosis, where patients might have a known low T-score, so they have weak bones, fragile bones, but they probably at age 40 aren't going to fracture. We might not need to treat them until they're 60, for example. Do we treat all individuals, or are there certain groups that are higher risk? In osteoporosis, somebody who's a frequent faller, someone with poor vision, someone with weak lower extremities, etc. Or you could think about stopping treatment as a decision that we really need to understand the relationship between the stoppage of a medicine and the outcomes. Also for, not just for clinical practice, but for public health, if we're implementing a screening program, when do we begin that screening program? So a screening program could be thought of as an intervention, just like prescribing a medicine is an intervention. What frequency do we screen patients, and until what age? And decision-making needs to be informed by causal knowledge about comparative effectiveness, and I would say, and safety. Obviously, we want to know whether interventions are efficacious or effective. Efficacious being the terminology we use from a randomized controlled trial. Effectiveness, we use that terminology when we're thinking about observational data. So efficacy means something specific. Effectiveness means something different to an epidemiologist. And safety is obviously part of the whole equation when we think about the risks and benefits of any intervention. So how do we learn what works and what harms? Another way of saying that for the epidemiologist is, how do we estimate the causal effects? And the standard scientific answer is conduct a randomized experiment. And obviously a randomized controlled trial is what we'd love to do for everything in medicine, but we'll never do that. Too expensive, it costs too much, takes too much time, often not really ethical. So we use, a relevant randomized trial would, in principle, answer each causal question, about comparative effectiveness and safety. So if we had all the time and money and ethics wasn't an issue, we would do RCTs. I'm an epidemiologist, but I would rather see data from an RCT than any observational study in all circumstances. But we just don't have them. So we have to think about how to use observational data more intelligently. So randomized trials are expensive, sometimes unethical, sometimes impractical, and almost always untimely. And deferring decisions is not an option. No decision is a decision. It maintains the status quo. So what do? As epidemiologists, we analyze observational data, but we need to do that in a very intelligent manner, else we confuse ourselves. And as an editor, I see confused association studies on a daily basis, as does Kelly. So research data are data that are collected specifically for research, like a cohort study, a prospective cohort study, the nurse's health study, the physician's health study. Often case control studies are collected specifically for research. A biobank is collected for research. We have lots of disease registries in rheumatology, and these are all research type data. But there's also this other type of data that many of us like to use, and I'm going to call it found data, data generated for non-research purposes from electronic health records, insurance claims databases, people call them administrative data, or sometimes national registers, cancer registries, death registries, etc. The pharma companies have called these RWD, real world data. They're just the data that many of us have been studying for decades, or routinely collected data. There's nothing special about these data. They're just sometimes easier and cheaper to gather. Of course, data from real world practice has a lot of value because it's from typical practice, but it comes with all kinds of limitations that we just need to be aware of and think about how to limit those limitations. So observational analyses are not preferred. I'm an epidemiologist. I'd always rather see an RCT. But we can think of, for each observational analysis for causal inference, we can imagine a hypothetical randomized trial that we would prefer to conduct, if only it were possible. And that's what we call the target trial. I am the co-PI on a trial called Target that was an acronym. This is a different target. This is the target trial, which is the trial, the hypothetical randomized trial that we'd like to conduct to answer a causal question. It's not the target trial about cardiovascular disease and RA. We're not talking about that today. A causal analysis of observational data can be viewed as an attempt to emulate a target trial. If we cannot translate our causal question into a target trial framework, then the question is probably not well defined, and you should go back to the drawing board and think about it again. And again, I'm borrowing stuff that my colleagues Miguel Hernan and Jamie Robbins from the Harvard School of Public Health have written about for years. These are not my ideas. I'm just telling you how these can be applied in rheumatology and in a minute, we'll get to some osteoporosis examples. So the first thing that Miguel and Jamie talk about is asking a causal question, specifying the protocol of the target trial, and then trying to answer that causal question. Again, option A is to conduct the trial, the randomized trial. Option B is to emulate the trial. Target trial emulation is what we're talking about today, and it's what we do as observational epidemiologists. We need to draft the study protocol, construct a causal framework, and then we need to find the data that will help us answer the question. So what is the clinical question? What is the target trial protocol? And how can we emulate an observational data? This is what we do when we're doing a randomized controlled trial. And what I'm suggesting, and Miguel and Jamie have suggested in the concept of target trial emulation, is that as observational epidemiologists, we should do the same thing. We should have the same orthodoxy. We need to define the questions. We need to define all these aspects before we go to the data. Too often people say, I have a pile of data. what can I analyze? What can I figure out from these data? It can't be done that way. It has to be done in the reverse to do it cleanly. We need to come up with a question, and then we have to develop the protocol, and then we have to think about whether we can emulate the trial protocol in observational data. And that means that we have to spell out the eligibility criteria. What are the specific treatment strategies we're going to compare? How do we think about randomizing the assignment? And obviously in observational data, it's not randomized. So we have to think about how that assignment to a given intervention, a given drug happens, and whether there's certain biases that likely confound that assignment. We have to think about the beginning, the start, and the end of follow-up. Oftentimes we talk about the start of follow-up as the index date, time zero. We need to be able to define the outcomes and make sure they're validated outcomes. Hopefully those have been validated in other studies. We don't want to just assume that if someone's been diagnosed with RA ×1 that they have RA. They probably don't. 50% of people diagnosed with one RA code don't have RA. So we really have to think carefully about the validation of the outcomes. We want to think about the contrast, the causal contrast. What is the other strategy, the reference group that we're going to compare our intervention of interest to? And then we have to develop the analysis plan. And this needs to be done before we go and analyze the data. We're going to end up biasing our analyses if we do it post hoc. So I'm going to give you a couple of examples of target trial emulation. And they're written out here. First, we're going to talk about delays in denosumab and fractures. And then we're going to talk about denosumab and diabetes risk. These are two studies that I've been senior author on that one of my colleagues, Hu-Chen Liu, who's an orthopedic surgeon in Beijing, who came and spent some time with us here in Boston, was very interested in osteoporosis and very interested in target trial emulation. And he really led these two studies, and so he deserves all the credit for pursuing these analyses. So again, ways to think about the effects of denosumab treatment gaps. And I put here quality of evidence because, at the top of that pyramid is meta-analyses of randomized trials. We might do a systematic review of randomized trials. We might think about an evidence-based guideline. Most of us who have been involved in guidelines know that the evidence is often pretty low quality. Many rheumatology guidelines, unfortunately, are very low quality. We can think about randomized trials and then non-randomized controlled trials. So what we're really in this non-randomized controlled trial or cohort study with most target trial emulation. And I list here that biology can help us understand treatment gaps, because if you go to the osteoporosis bone biology literature, you'll see all these like hand-waving experiments with denosumab, stopping it, what happens to the osteoblast, the osteoclast, and bone quality. But like, that's nice, and that might underpin what we're observing in clinical practice, but we really want to see what happens in clinical practice, either a trial or a target trial emulation, like I'm going to show you. And so again, clinical science is what we're going to focus on. The RCT of different denosumab treatment gaps would be unethical. We can't say, oh, all the trials of denosumab were done with 6 month gaps, but Mrs. Jones, we're not sure why 6 months was chosen. It was kind of based on some biology, the pharmacokinetics that Amgen thought was important, but we're gonna randomize you to 12-month treatment gap. That wouldn't fly with an IRB. And so you can't do that. But we don't really know what's the right treatment gap. And this became really important during the COVID pandemic, where it was sometimes hard to get people in. Like, how important was 6 months versus 7 months versus 9 months versus 12 months? And so Hu-Chen thought that was an important question to ask, and I agreed, and we kind of pursued it with a target trial emulation. So this is the paper. It was published in Annals of Internal Medicine in 2020. Again, Hu Chen is the first author. Kazuki Yoshida, a very talented rheumatologist and epidemiologist and biostatistician, who now works in industry. Ben Leaders, an osteoporosis expert at Mass General, and some other folks, including Sarah Tedeschi, and then I'm the senior author here. So the question that we asked is there an increased fracture risk among patients who delay their denosumab? If you know this literature, there's lots of case reports, case series that say, oh, if you delay it, it's very bad. But really, case reports, case series are low quality evidence, we all know. And so the methods that we outlined were using the THIN database, which is a UK primary care database. We had data from 2010 to 2019. At the time, persons aged 45 years or older who initiated denosumab for osteoporosis were potentially eligible. The observational data were used to emulate the hypothetical trial with 3 dosing intervals. So these were our strategies that we were contrasting with each other. We wanted to know whether the next denosumab injection was on time or within 4 weeks of the 6-month delay. So if you're a clinician, you know that we're supposed to wait 6 months before giving denosumab, DMAB again. And if it was 5 to 7 months, we called that on time. And if it was delayed from 1 to 4 months, we called that a short delay. And delayed by more than 4 months, 16 weeks, we call that a long delay. And this is, as a clinician, that's like, you know, this is what we see in practice. Patients don't always come in when we ask them to come in. Sometimes the healthcare system doesn't work. Isn't that amazing? And the primary outcome was a composite of all fracture types at 6 months after the recommended date. So we wanted to look at the period after we thought people, the literature tells us patients should get it at 6 months after their prior infusion. So we wanted to look between 6 and 12 months for the outcome of interest, different types of fracture. And we defined some secondary outcomes: major osteoporotic fracture, those are hip, mostly vertebral fractures, specifically different types of fractures in different anatomic areas. Vertebral fracture, hip fracture, non-vert fracture were the secondary outcomes. So you can kind of, look at this observational corollary to the target trial as such. So there's all the patients have osteoporosis, and now we're going to pseudo-randomize them to denosumab without delay within 4 weeks of when they're supposed to get it, a short delay, 1 to 4 months of when they're supposed to get it, or a long delay beyond 4 months. And then we're going to look at these outcomes in the blue box over here. So we outline the eligibility criteria, treatment strategies, randomized assignments, start and end of follow-up, outcomes, causal contrast analysis plan. And we define these inclusion and exclusion criteria. I'm going to kind of breeze through some of the details because we're really talking about the generic concepts around the target trial emulation. There were 3 treatment assignments. The complicated part of this study, which is not that common, but it's not that rare, and it made the study complex to conduct and to describe, to be honest, is that the 3 treatment assignments are impossible to determine at baseline because the treatment assignments are not assigned at baseline. They're only assigned during follow-up, because that's when we figure out whether someone's had a delay. You can't figure out if they've had a delay, a short delay or a long delay at baseline. You only figure that out after you observe them. And that kind of breaks one of the rules of epidemiology. We can't adjust for things. We don't like to figure out people's exposure status after the start of follow-up, because then there's reverse causation. There's all kinds of confounding and bias that could enter into this. So we did, I would say Hu Chen had thought of creative ways of trying to figure this out. And we consulted with some of our colleagues at the Harvard School of Public Health, and I think we managed it well. And the other thing is that there are repeated cycles of treatment. So people are treated every 6 months, hopefully, but it may be that in cycle 1, they delay 1 month. So we would call that no delay. And in cycle 2, they might delay 2 months. That would be called a short delay. And in cycle 3, they could delay beyond 4 months. They could be a long delay. So these different cycles are they're like randomized experiments. So you have to think about these subsequent cycles as new experiments. And then how do you deal with those data? Because they're being observed in the same patient. So they're not independent observations. They're highly interdependent, correlated observations. And so the analytic strategy has to kind of outline that. And I'll talk about that in a little more detail, but those are some of the tricks of this analysis. So usually in a target trial emulation, you want to show this kind of a figure. And my colleagues in the Division of Pharmacoepi wrote a nice paper in the Annals of Internal Medicine about 5 years ago. I think Sebastian Schneeweiss is the first author. And they talked all about this figure. And if you've been at this kind of pharmacoepi causal inference work for a while, you've made figures like this because it's the right way to do it. But this Annals paper that they wrote kind of described it in great detail. And I said to Hu Chen, you better make this figure because we need to understand it. We're going to show it as a supplement, and the Annals of Internal Medicine will eat it up. And they did. So you can see here where we define the covariates, where we define eligibility, that patients have different delays as shown in red. And then we look for outcomes during this follow-up window, and then another cycle begins after they get their next infusion. So this is a very important figure that I would really encourage people to think about carefully before you embark on a study. Okay, this is the really complicated part of the study that you start with this original population, and at time 0, at the index date, you don't know if they're going to be no delay or this minimal delay, short delay, arm 2, or long delay, arm 3. You don't know that. And so what you do is you clone the population, and you say they could be in arm 1, arm 2, and arm 3. And then over time, we're going to figure out which arm they're in, and we censor them from the arm that they're not in, because they declare themselves to be a no delay, short delay, or long delay, and they get censored. And then that censoring tells us how to weight people from the original cohort, right? So you can see on the far right that we will downweight people who eventually didn't stay in arm 1. We will downweight people in arm 2 who eventually weren't in arm 2, i.e. they were long delayers. So, they would have full weighting if they were long delayers for arm 3, but they would be downweighted in arms 1 and 2 because they get censored over time, because we figure out who they are, what their exposure status really is. And this cloning and censoring is you can read, I'm not such a smart epidemiologist, but there's a lot of theoretical epidemiologists, School of Public Health, who have written lots of papers. I think Miguel Hernan is on a lot of those, and some other people who have done some great work. And we used this methodology, and there's a lot of code that's been written that makes this easier to follow. The outcomes I've described are fractures. We had a primary, we had secondary outcomes, etc. We thought long and hard about our statistical power based on the population at risk and what we anticipated the outcome rates would be over time, because we knew what our follow-up period was. And so we actually, Hu Chen did a lot of pre-planning statistical power calculations, which was very helpful. And it helped us think clearly about primary and secondary outcomes. And I would encourage you to do that and not change your outcomes post hoc, as we know people do. This is our this is how the cohort was assembled. And you could see that we had all these exclusion criteria that we applied. We ended up with this eligible population. We cloned this group into this on-time, short, and long delay regimens. And then we had people that were censored and weighted, et cetera, based on what I just talked about. And this is what the study population looked like at baseline. It becomes complicated because you also have a weighted study population, and we had long debates with the Annals of Internal Medicine about whether table 1 should be the weighted population or the non-weighted population, and that's kind of a philosophical discussion that I'm not going to get into today. These are the 3 cohorts: the on-time, short delay, long delay, and how they differ. The point that I want to make is that the standardized mean differences, the SMDs, which is another way of thinking about how different these groups are, how well balanced they are. What we care about in table 1 is balancing the covariates across our different populations. Now, I just said different, but you can correct me and say, but Solomon, you just told me that you cloned the population, so they really aren't different. This is the weighted this is the weighted differences. So there is some differences between these groups, but you can see that the differences between the short delay and the long delay are minimal. They're like in the 3rd or 4th decimal place. And so the SMDs are very, very small. We kind of use an SMD of 0.1 as our threshold. We want our SMDs to be below 0.1. The smaller they are, the better balance we have in the measured covariates. Measured covariates. This is not a randomized trial. The beauty of a randomized trial is that you're balancing known confounders that you can list in table 1, but you assume that all the things we don't understand, unknown potential confounders, are also balanced if table 1 shows balancing in the measured covariates. So we don't know that everything that's unmeasured, because that's kind of those are unmeasured. But it's nice to see that the things that we can measure that are listed in the left-hand column have these small SMDs. So this is the results table that, you could see that there's the unadjusted hazard ratio 1.45 for long delay compared to on time. The short delay did not show a significant increase in anything. And there was borderline significance in a lot of things. This sensitivity analysis was the same, except we had patients, we kind of dealt with some issues with excluding certain patients who had a fracture that was very proximal to their first denosumab. And there's reasons that I can get into about that, but this showed a higher hazard ratio. But as you, as you look at these different outcomes, you can see that the patterns are very clear. Long delay is associated with increased risk, sometimes barely statistically significant, sometimes not significant. When you look at vert fractures, you have a very strong effect. And this kind of jibes with the biology of denosumab and vert fractures that we could talk about if people want. And then hip fractures, there's not that many hip fractures. You can see that the number of events is fewer, and therefore the confidence intervals are wider, and therefore we don't see a statistically significant increase, but numerically we see an increase. And this is just the cumulative incidence curves, a different way of showing what I just showed you with the hazard ratios, but very similar results. It's kind of interesting to see the time course, that it takes time, over time, you see that there's a divergence of the curves. It's out to 20 weeks. So you can kind of think that a lot of the people that had delay were really long delays. And you start to see the divergence in the curves out there. So it might be that, I don't like to tell patients this, but it might be that delaying a month or two is not that big a deal, or even 3 is not that big a deal, except when you get into certain types of fractures. Vert fractures, it looks like they start to diverge earlier, right? So this is, it's kind of interesting. It jibes with the biology, and it gives some important numbers to an issue that a lot of us who practice osteoporosis care think about. This is some subgroup analysis that I'm not going to get into, just because we won't have time to talk about a second example. So limitations, delays are not randomized. This is not a randomized trial. We are observing found data. It's a complicated method. This clone and sensor is hard to explain. The Annals likes complicated methods, so it was the perfect place to send this paper. Relatively few patients were followed for very long, so that reduces the statistical power. And it's a UK primary data set. Does it not apply to the US? I don't know. It probably does. Does it apply to other populations, Asian populations, South American, African? Maybe not, based on genetics, et cetera. So strengths is really the strengths of the target trial emulation. Causal inferences are much stronger than typical drug epi models. And we were able to effectively deal with the exposure that was defined after the baseline, and with the multiple cycles of denosumab. So before I go on, I'm happy to take questions now. The next example is about 10 minutes, so we'll have 10 minutes at the very end. What do people think? Do people want to ask questions now, or it depends on the crowd? I'm happy to do either. I'm looking around the proverbial room. I don't see hands going up. I don't see anything in the chat box, so I'll just keep going. Unless people want to start yelling. Okay, so let's go on to the next examples. This is another paper that was published. Hu Chen's the first author, and this was published in the BMJ, I think in the last year. I can't remember. And we wanted to assess whether the use of denosumab is associated with a reduced risk of type 2 diabetes compared to oral bisphosphonates in individuals with osteoporosis. So this is kind of an interesting question. It's different than the prior question because this is kind of like an I'm going to say off-target potential benefit that the biology of denosumab has suggested. And there's been small studies that say that denosumab might have some effects on type 2 diabetes risk, but no, we actually talked to Amgen, the maker of denosumab, and they said, we're not going to run a randomized trial. Be my guest to do an observational study. So we decided to pursue it this way. It's a population-based cohort study using a UK data set that IQVIA, we were able to use from IQVIA, 1995 to 2021. Individuals are 45 years or older who used denosumab or oral bisphosphonates for osteoporosis. And the main outcome was incident type 2 diabetes, defined by diagnostic codes. Okay. Again, this is some of the prior data that made us wonder about this question. And this is data from trials. FIT is an old alendronate trial. This is like a very, very early alendronate work where there was no change in risk. Horizon used was zoledronic acid, a different anti-resorptive agent, bisphosphonate against placebo, maybe some tiny reduction. Freedom was actually denosumab, and there was a 15% reduction, but it wasn't powered to look for diabetes risk. When you pool this all, It's kind of a non-significant pooled result for anti-resorptives. And so, no one really knew. And so we thought this was an interesting question that we could ask using this target trial emulation. And this was a meta-analysis that, again, suggested that there might be some effect on diabetes risk. The Freedom study, which was a denosumab study, also showed a 15% reduction. So there was some data to suggest this. And another reason I put this up is that doing a meta-analysis of RCTs is a great way to look at off-target effects of drugs. So when people come to me and they say, oh, I want to study a big data set and do this drug epi study, I say, have you thought about whether you can do it using a systematic meta-analysis? Because, randomized trials are always better than observational data. Even though I'm a drug epidemiologist, I'd always rather see the target trial or a meta-analysis of the target trial. So there is some data that made us think about this, and we looked at this pyramid before. I'm not going to do it again. So the target trial emulation, you have to define all these domains of the target trial, and here we do that. We have the target trial specifications, and we think about exactly the same sets of issues in the target trial emulation. And the good news is that we were able to really emulate it very closely. And so we felt like this was a great example. And we would come up with an answer that we thought we would have strong causal inference about. So we created the same figure that I showed you before, where we look at the inclusion and exclusion windows. We define covariates. And then we define the exposure status, and then we have this follow-up window here. And we think about our population. Here's the users of oral bisphosphonates. That's going to be the contrast against people who use denosumab. That's going to be the exposure of interest. We apply the same exclusion criteria. We have our eligible populations, and then we had some further exclusions, and then we propensity score matched patients. We really wanted to retain all of the denosumab users, so we did I think we did an N-to-1, so we could match multiple oral bisphosphonate users to the denosumab users. And then here's our baseline table 1 characteristics. You can see the standardized mean differences are really tiny for all the things that we can measure. Obviously, we don't know what we don't know. Body mass index, physical activity, things, there's good data on BMI in the Quivia database, so we have some of that, but there's other issues that might impact type 2 diabetes risk that we don't have information on. So that's very important to be clear about. And the main results, just kind of skip there, is that we saw, a 30% reduction in the risk with denosumab users compared to oral bisphosphonate users. And here our primary outcome was defined by type 2 diabetes diagnostic codes. And then we did a secondary outcomes analysis where we also included anti-diabetic meds and some lab results. We did have some hemoglobin A1Cs and things like that. And it's a very similar result. So it's a very robust result, no matter how you define the outcome, which gave us greater confidence that this was a real result. And again, we see the cumulative incidence curve. Now, it's kind of an interesting point here about the cumulative incidence curve, is that you see that within about 3 or 4 months, there's actually the curves begin to diverge. And people have written about whether, if the curves diverge too early, is that a suggestion that there's some confounding? And it can be, but the biology of how denosumab might reduce the risk of type 2 diabetes suggests that after a few months of the first infusion, you might actually get a reduction in type 2 diabetes risk. It doesn't happen immediately. It takes a couple of months to see, maybe 4 to 6 months. So but that's the time curve, I think, can be quite interesting and important in thinking about whether this might be a causal effect. We did some subgroup analyses that give us similar results, so I'm not going to go too deep into that. These are sensitivity analyses that change the exposure. We looked at competing risk of death. We lagged the time. You can see that the hazard ratio is incredibly robust. No matter how we analyze the data, you can see the number of events changes as we change definitions, but it gave us confidence that this was a very solid finding. Again, I don't know that it's causal, but it suggests or infers causation. So the limitations are, we had to mix prevalent and incident users of alendronate, which is a little bit not what you want to do. You always want to do a new user analysis, incident user analysis. But we did in sensitivity analysis, we took out the prevalent users. It reduced our sample size, reduces the number of events, confidence intervals get wider, but it really was almost the same point estimate. Obviously, residual confounding, unmeasured issues like diet and exercise, misclassification of outcomes is always an issue that you need to be aware of. The target trial emulation is the clear strength, and we talked about the strengths of that. So, one of the points that I'll make here, that this is a slide that I borrowed from my colleague Sebastian Schneeweiss, a really smart drug epidemiologist, is that, when we start with the full cohort of incident and prevalent drug users, we have this huge population, but there's all kinds of biases. And as we restrict further and further by incident drug users, on non-users and in system use and comparison drug users, we get closer and closer to a randomized controlled trial. The randomized controlled trial is the tiny box down on the far right. And the tiny box in the far right is where there's the least bias, but perhaps there's a problem with generalizability. And so you need to find, as an epidemiologist, our job is to find the sweet spot in this series of boxes. And that's like what a PhD in epidemiology learns, or a master's in epidemiology learns. So methodological conclusion, the target trial is an important concept in comparative effectiveness. Carefully designed observational analyses can complement RCTs, or maybe the best substitute when RCTs are considered unethical or too costly or too timely. Having a large sample size can be helpful, but it does not allow one to make stronger inferences. Causal inference, causal effects analyses can be useful, but they don't prove causation. And we'd always rather do it in RCT. And I will stop there. I put Hu Chen's picture here because he wasn't pictured in this picture of our section of clinical sciences here at the Brigham. And I wanted to thank UNC TARC, and Verity is our P30, and we're happy to collaborate with all the P30s across the country. So I'm glad to take any questions now.
Thank you, Dan. For anyone with questions, feel free to, or really anybody, feel free to go ahead and put your video back on. I think we'll do fine with that. And I don't see any questions in the chat yet, but feel free to unmute yourself. Oh, there is one question. So Dan, I'll read this just for everybody in case any folks are in places I can't see it very well. Question about the first study you discussed. The study design of target trial emulation depends on the grouping treatment delay. Is it also possible to use the raw delay quantitative data? Are there pros and cons? I'm not sure if that means like as a continuous variable. If that's not the right interpretation, whoever put the question, feel free to clarify.
So, yes, so it sounds like, John, you meant using the data as continuous delay. And the problem with doing it as a continuous delay, we thought about that, but the problem is that the interpretation of the continuous data is tricky. We would have found that delay is associated with increased risk of fracture, but we as clinicians, we'd like to be able to communicate. If you delay X amount of time, 1 month, 3 months, 6 months. And so that's why we decided to do this categorization of the delays. But we could have, statistically, it would be easy to do it as a continuous variable. It's just a little trickier to communicate it. Good question. Always comes up. What are your thoughts on implementing TTE in community-based cohort studies? Do not have EMR data typically, and may not have a patient participant exposed to each treatment arm. Yeah, it's really it's sometimes more challenging to do EHR based than honestly, thin data is from an EHR. It's derived originally from an EHR, but then there's more data added to it. EHRs have missing data. This is the problem with EHR analyses. We're doing one right now where we worry that patients, they go to Florida. If you live in Boston, you go to, a lot of people go to Florida, or they go to North Carolina, or they go to somewhere warm, and they then become, we're blind to their data, and so we then have to do all these tricks to make sure we have complete data. We censor them at certain, where we don't have any data, we censor them. And so it's trickier when using EHR data, where people might migrate out or spend time out of the system. So Deepak, I think that your point is a good one. And it takes a lot of thinking about why you might not be seeing things in your EHR data, and then maybe creating censoring rules. And that's what we're doing. Right now, we have an interesting analysis on metformin and the risk of gout, where this was a particular issue, and people starting metformin for prediabetes appeared to be more likely to stay in our health system. And so we had to do some interesting things to deal with that. Anyway, it's kind of a half answer, but it is a trickier in an EHR data environment.
And Dan, I'm looking at Deepak's question and wonder if he's also wanting your insight on other types of data. So maybe registry based or other cohorts that are, maybe de novo data collection. It's an observational cohort study, which my thoughts about that is that often that means less data, right? I mean, an EMR, EHR study, they're not, we don't have everything we'd like, but there's typically a lot. So, potentially one challenge with cohort-based studies is the ability to match, depending on what data are there. So I don't know if you have any comments on applicability to those types of studies, or maybe strong examples you've seen in those kinds of study environments.
Yeah, so this gets to is a lot of issues that we could discuss here. You spend a couple hours discussing okay, so maybe you want to do a case control study. Case control studies are always a bit more problematic when you're trying to figure out causal inference. And so I hate doing case control studies. I say if you have all the data, do a cohort study, because then you're kind of emulating a randomized trial. A randomized trial, you start at time 0, you follow people forward, you look at their exposures, and you can understand the incidence rates more easily than in a case control study. However, sometimes a case control study is all you can do, but your causal inference is going to be weaker in a case control study, always. We often do case control studies that are nested within a cohort. When you understand the full cohort, nesting a case control study is more, I'm more comfortable with that. And we do that often in biomarker studies, because we don't want to run expensive biomarkers on the whole cohort. We want to run them on all the cases, and then 3-to-1 match on, controls. And that's cheaper and more efficient. And you're less interested in causal inference when you're doing a biomarker study than when you're looking at an intervention like a drug or some other sort of public health strategy. So that's one issue. The second issue is that there's missingness. Missingness depends on the data set. And so when you say something's a registry, like I want to know the details of that registry. Like how good a registry is it? Did they make patients come in every 3 months? Did they collect all the data every 3 months? Like there's some registries which are great and some registries which ain't great. There's some EHRs where you have a lot of missing data and less some EHRs where you don't have as much missing data. So you have to look at the specifics of the data set and don't rely on the labels of the data set. You know, registry EHR, I don't really care. Tell me, like, let me understand the guts of that data set and how much missingness there is and what's there and what's not there. I hope that's helpful.
Yeah, thanks, Dan. We just have a couple minutes. Any final questions, comments?
So I'll say in closing that target trial emulation and causal inference modeling sound fancy. Propensity score matching used to sound fancy, and they're good standards to operate by. They don't make your study better necessarily. They're just like a set of methods, a way of thinking about observational data, which can be very useful, but it doesn't mean that it's true, and not doing it doesn't mean that your results are not true or valid or causally related. They're just ways of conceptualizing observational studies that I think are very useful. And so it's just a tool, just like comparative effectiveness was a label. Propensity score matching is a way of dealing with balancing. But, you know, Michael LaValle could tell us, you know, if you do a good multivariate regression, you can balance stuff well. Like, you know, propensity score matching doesn't really, you know, has certain nice properties, but doesn't make your study correct because there's a lot of unmeasured stuff. So anyway, I hope that's helpful. Good to see a lot of friends, and I imagine I'll be seeing people, I don't know, in Vienna or somewhere soon, hopefully. Good.
Thanks again, Dan. We appreciate it. That was, I think, a really helpful summary of this method. And if you don't mind, there will be a questionnaire that pops up on your screen when we're done.